good evening to juries and members of the floor. Our topic today is National Transfusion Practice Guidelines, Clinical Audit on Adherence to Blood Ordering Procedure for Transfusion among Junior Doctors in Hospitals in Jaya. As we all know, nowadays, blood transfusion has become an integral part of patient care. It saves lives and it is meant to benefit the patients. However, it's very important for all of us to remember that blood transfusion is not without risk. ABO incompatible red cell transfusion occurs with the most feared risk, as it may result in disastrous outcome and potentially fatal. The drawing of blood sample from the right patient for pre-transfusion compatibility testing is the most critical step in the transfusion process. Errors in the pre-transfusion blood sampling can initiate the wrong process and may lead to major ABO incompatible red cell transfusion. If a major ABO incompatible transfusion occurs, it will definitely result in disastrous and catastrophic outcomes which are potentially fatal. Following that, it will result in a lot of expenses to be spent to pay for the consequences and not forgetting the litigation costs, which can cost us millions and millions of ringgit. Apart from that, following an incident, it will also have major psychological impact on the staff involved, in which all will lead to poor performance and loss of productivity. So this statistic shows the near-miss and blood transfusion error cases in our hospital from 2014 to 2017. As you can see here, even though the frequency of near-miss events has reduced over the years, we still have one case of transfusion error last year, which occurred due to failure to comply with standard operating procedure in blood taking. When we look further into the statistics of near-miss, we can see that blood sampling and labeling error remain as a significant problem. Besides, we also observed an increasing trend of sample rejection in our hospital in 2017. And this increment in sample rejection actually occurs throughout the hospitals, in every department. So when we look into the reasons for sample rejection in blood bank in our hospital during 2017, we identified that again, blood sampling and labeling remain as a major issue. So why do we choose this topic? Ladies and gentlemen, we chose this topic because the root cause analysis on all near-miss and transfusion error cases in 2017 revealed failure to follow standard operating procedures during blood taking by the house officers. Besides, we also observed increasing trend of sample rejection in the lab resulting from inappropriate transfusion practice in the pre-analytical area, in which all this can lead to delay in blood supply and compromise patient care, as well as result in a lot of wastage of many resources. From the data that we have, we concluded that inappropriate transfusion practice is a significant problem in our clinical area, and therefore, immediate remedial action is indicated to stop these unsafe practices for our patient safety. According to Ashish Chin et al. In 2015, errors made in the collection of patient sample for pre-transfusion compatibility testing are serious because they are at the beginning of a complex chain of the transfusion process. In 2011, Nur Hasrina et al. Reported that mislabeled and miscollected samples are a significant problem in the clinical area, and medical staffs are the most frequently involved in sample collection errors, including the house officers. Kavinda et al. In 2014 emphasized that lack of knowledge of the medical staff in transfusion is obvious, and therefore there must be regular training and follow-up activities. The general objective for this study is to enhance adherence to the National Transfusion Practice Guidelines in ordering blood for transfusion. Our specific objective include to increase knowledge on appropriate blood ordering procedure for transfusion among the junior doctors, to improve blood ordering practices among the junior doctors to ensure best patient care, and to reduce the incidence of near-miss and transfusion error due to inappropriate blood ordering practice. Our criteria is adherence to National Transfusion Practice Guidelines when ordering blood for transfusion, and our standard is 100% adherence. These are the definitions used in our study. This study is an observational cross-sectional study which was conducted in our hospital and involved 80 house officers in Hospital Seberang Jaya within 2 years of service. Those 80 house officers were selected using systematic random sampling method, in which 40 of them were involved in the pre-remedial audit and 40 involved in the post-remedial audit. Our data were collected using self-administered questionnaire and direct observational checklists, which both adapted from the National Transfusion Practice Guidelines 2016. We conducted this study from January to October this year in all clinical departments with house officers in Hospital Seberang Jaya. So this is the transfusion practice guidelines that we referred to. These are the tools that we use for our study. So during the pre-remedial audit, on assessment of knowledge, we identified that the house officers scored poorly, in which they have poor knowledge on filling out of request forms. On assessment of practice, we noticed that they have poor adherence to the patient identification procedure. The reasons for shortfall in quality include lack of knowledge on procedure for ordering blood for transfusion. Junior doctors were not aware of the latest transfusion practice guidelines available, lack of monitoring and supervision in wards after the orientation program, and weakness in the orientation program by Department of Pathology. As for strategies for change, for lack of knowledge, we had conducted remedial CME on safe transfusion practice in all clinical departments, in which we targeted all house officers in the department. We also conducted focus group discussion during the end of the audit, in which we highlighted the weakness in the audit and way to improve. For poor transfusion practice, we had included hands-on sessions during the remedial CME session, as well as the orientation program for the house officers. For lack of awareness on transfusion practice guidelines, we had introduced online user manual and latest transfusion practice guidelines during the orientation program. For lack of monitoring in ward, we had conducted a course, Safe Transfusion Practice course, training of trainers, in which we targeted the clinical supervisors, who are the medical officers and ward sisters, to monitor the house officers and to have knowledge on transfusion practice. We also have hospital transfusion committee meeting and meeting with head of departments to discuss about transfusion related issues and strategies to improve. And now we also have verification of all GXM and GSH requests from the wards by the staff nurses before they are sent to blood bank. To improve the orientation program for the house officers, we also include hands-on session and discussion about transfusion-related scenarios in the orientation program. Besides, we also included demonstration of blood-taking technique in our blood-taking room. So, during the post-remedial audit, on assessment of knowledge, we can see that there was significant improvement in knowledge on blood ordering procedures throughout. And on assessment of practice, there is also significant improvement in adherence to the blood ordering procedures throughout. And for near-miss and transfusion error in our hospital, there is significant reduction in near-miss and transfusion error cases in our center, in which until today, we only have 4 near-miss cases and no transfusion error reported. In conclusion, the findings of this audit showed, number 1, significant improvement in knowledge and adherence to the standard practice after remedial measures taken, and secondly, there is significant reduction in near-miss and transfusion error cases. In conclusion, we can conclude this study as able to save costs, save time, save many other resources, and most importantly, it is able to save lives of patients. As for next step, the second phase of this audit is currently in progress. Safe blood transfusion practice will be routinely emphasized to all staff during new orientation program, CME, CNE, and bedside teaching. Continuous monitoring by head of department and clinical supervisors on safe blood transfusion practice is necessary to ensure compliance. Hospital Transmission Committee meetings with hospital director and head of departments will continue as a platform to discuss about transmission practices and strategies for improvement. And of course, regular audits on safe transmission practice will be carried out to improve transmission knowledge and practices among the medical staff in hospitals of Ranjaya. So these are our references. And with that, thank you for your attention.
Thank you. A good presentation. Actually, by the words, this is good lah sebab kita clear dia punya message tu sampai kita. Topik itu common topik. So macam setiap tahun ada event QA ke apa mesti ada topik ni. Topik yang famous lah. Sebab masalah tu tak selesai lagi. That's why dia jadi famous. Okay. Cuma itu boleh tak going back to the slide. Cuma saya nak tengok analisis, data analisis yang kepada yang dihadapkan banyak department.
By department is the rejection.
Rejection. Okay.
By department is
macam department yang beberapa department yang highlight. Yang ni. Okay, yang ni memang kalau I nak zoom in, I interested yang ni sebenarnya, yang ni compare to dia yang general kan. Kalau ikut spesifik, yang ni lagi tinggi sebenarnya. Dia akan menyumbang kepada error, kan? Okay. Yang ni kita boleh catch up sebab saya pun reject, kita boleh catch up. Tapi kalau dah terjadi memang tak boleh nak catch up lah. So kat sini macam pada saya lah sebagai pengalaman okay. Kat sini kalau you boleh tackle okay, kita tengok tau dia punya complexity of the department itself. Macam AE compare to medical, compare to surgical, PACE, ONG, NS and auto. Which one is more yang kita rasa critical untuk kita elakkan? Maksudnya maksud saya macam ni. Kalau contohnya department emergency compare to NS. So kita tengok length, duration, patient bersama dengan staff and patient dan prosedur. I rasa kalau you zoom in ke situ, you boleh reducekan each department tu. Maksudnya mungkin the next lah, I rasa the next audit, I rather pilih department yang memang critical. Maksudnya kalau emergency. So what happened to the nature of the emergency? So kat situ you kadang-kadang nak cross check, double check, third check pun kadang tak ada orang nak buat. Yang doktor tu lah doktor yang akan check sendiri. So kalau compare dengan department yang memang dia second wave tu, maksudnya dia boleh tunggu lagi. Kat situ akan ada orang akan cross check lagi. So it's safe lagi. So for me untuk tajuk ni sangat common dan memang saya rasa kalau banyak tempat dah akan bila topik ni lah sebab kita nak tengok kan dia punya keberkesanan implementation. For me, I better pilih department yang kritikal comparing dengan department yang kirakan macam chances tu less sikit untuk terjadi error. So kita boleh buat dekat situ. Maksud I, kecemasan is the first lah, priority. Yang keduanya DOT kan. Tapi for me, kalau tadi kalau ikut touching tadi kan kita menggunakan junior doctor kan, kita aim at junior doctor. So for me is not about the junior doctor, a person yang keliling junior doctor tu. Maksudnya junior doctor dah buat mistake, so siapa yang cross check lagi? Staff lah, barang medik. So for me, you jangan segregatekan junior doctor saja. I rasa you kena improvekan yang staffing kat tepi tu memang ada contribution juga untuk dia di error tu. So macam saya rasa macam untuk shortfall tu kita tak boleh kata only junior doctor yang kita nampak. Macam tu. So kalau kat sini nampak tajuk tu memang ke junior doctor. For me siapa yang cross check dia adalah orang yang sekeliling dia. So lepas ni macam for me lah good topik, tapi you space you dah ada data kat situ untuk analisis dah ada, dah nampak dah. So macam mana nak reducekan nombor-nombor tu dekat setiap department. So you kena go by priority. So satu lagi about the staffing teamwork sebab rejection ni belum terjadi sebab ada faktor teamwork kat situ. Kalau Umang Isyani just seorang kita point the finger, I rasa is less lah, macam tak berapa sebab junior doctor is still under supervision by MO and then dibantu oleh paramedic. Ini kita rasa topik ni interesting tapi you kena detail sikit maksudnya tu sendiri. Sebab saya rasa data untuk yang analisis tu dah bagus dah. Cuma you kena detail sikit. Saya rasa kalau untuk general, untuk guideline tu junior doctor, saya rasa contribution banyak daripada yang klinik dia. Sebab junior doktor ni kata dia memang dia stick pada guideline, tapi how effectiveness kita assess orang klinik, adakah dia maksudnya kita akan cross check dengan orang lain lah. So dari segi presentation saya puji lah sebab sangat detail dan sangat flow dia memang cara flow clinical audit lah. So tahniah.
Izinkan saya nak explain sikit tentang rejection. Kenapa kita tak buat tentang rejection? Because rejection yang kita sudah tengok ni kan, yang statistik ni is mainly like not as serious as near misses. These rejections are basically according to this criteria. So just because of no name ataupun mislabeling. But why we did this topic? Because of the near misses. Mostly because of the near misses. Because kita tengok kat sini, and last year we had one transfusion error. We are more worried about the near misses because as you can see in this graph, despite the number is decreasing, like last year we had total of 10, 3 from sampling error and 7 from labeling error. Why this 10 did not turn out to be a transfusion error? Because these 10 cases, they had previous blood group record in our blood bank. So we managed to capture those cases. If we do not have the previous record, those 10 will go into transfusion error. So why we had one transfusion error last year is because that one case did not have previous record. So when we get sample from the ward, we get group group O. Whenever the patient need the blood, we supply group O. Actually, the blood sample was taken from a wrong patient. The actual patient actually group B. And so we are more worried in terms of near misses rather than the rejection. Because the rejection is simple. Because for rejections, we have hemolysis, we have sample that the name was not written on the tube, the name and the label on sample was not tally. So it is kind of boleh maaf lagi lah. Tapi for near miss, we can't. And we see walaupun dia berkurang throughout the years, but it is still ada risk to become error, especially if the patient do not have previous blood group in our blood bank. That's why we chose this topic.
Kira-kira patut nak bergelakkan lah kan?
Very well presented. Everything in place. Anyhow, going back to your title, you're talking about the adherence to blood ordering procedure for transfusion among junior doctors. Okay, I have two questions here. Okay, first and foremost, you're talking about blood ordering procedure, okay, but you are actually emphasizing on only 2 or 3 things, right? Yeah, the labeling, things that you highlighted just now. So I would feel that in the title you should have highlighted that. Okay, right. It's just a comment. And the second one, I would like to know, during the period of your study of this year, from January till now, how many households or junior doctors that we are talking about that is in the picture in hospitals Pranjaya actually dedicated to the departments that you study?
Actually, in our hospital, when we did this study, we have about 200 house officers in the hospital. So the one included in this study is 80 of them.
How about the rest? They not do any blood transfusion?
No, they are not included as study participants. But when we go to each department for remedial CME, we also target them.
So we need to say that the results that you actually lay out in this project solely contributed by these 80 participants and not the rest.
Yes.
How about the performance of the rest which are not included? Maybe no.
The performance of the rest, I looked in a general picture at the near miss cases. So far, from the remedial CME that we did and the remedial actions that we did, until now there is no near miss reported. And our rejection is also coming down in trend. Like you see, last time it was 0.86, which is the standard is less than 0.86%. In 2017, we had 0.86%. But last month, when we analysed, it's about 0.6%. We can see the coming down trend. But as Dr. Ho mentioned just now, we need to give time for them to sync with it.
Thank you, Dr. Nisa, for exemplary presentation. So this is the approach that we always look for when we do a clinical audit. Your team must be congratulated. To do a collaborative, cross-departmental, multidisciplinary audit that involves all categories of staff, that which eventually not only translated to changes in the audit outcome, but more patient outcome, which is reduction in the transfusion error and also the near misses. There are just a few questions allow me to ask. That actually your gist of the audit is actually to observe their practice. Am I right? I suppose that because you start off putting out the knowledge rather than the result for the practices, so I get some time to digest. And how did you do the direct observations on the houseman, and do they know that you are actually auditing them?
Actually, when we selected the participants, we got the list of names from the unit pengurusan. So there were 200 house officers in the hospital, and we selected using the random sampling method every 2 names. Okay, then from the names that we got, we contacted them and we do appointment with them. So we wanted to meet them in the ward, and when we go to the ward, we tell them that we are going to assess. We tell them that we are going to assess their practice and knowledge, and we give them case scenario. Usually we'll say, okay, because we want to assess them, because we had already given them a half-a-day session on blood transfusion during the orientation program. So actually, together with that, we wanted to assess the effectivity of the orientation program. So we give them scenario. We say, okay, doctor so and so, now a patient at bed 8 need blood transfusion. Please take GXM sample from the patient. So the doctor will perform. Actually, it's more of simulation. Okay, but they will not tell us anything, and we are not going to say anything to them. We just observe from the beginning till end. Then until they send the sample, so then we have checklist, and we'll take the checklist and we calculated the marks according to their adherence.
Yeah, because I ask this question usually when the result is very good, we worry about Horton effect. And as if now that after you do the repeated audit, amazingly that despite they know that being audited again, after going through all the remedial measures, they still cannot achieve 100%. May I know why?
Actually, when we did the audit, like I mentioned just now, at the end of the session, we will have just a short discussion on what were the weakness they did and how to improve. Actually, to say 100% attitude, I'm not sure, but whenever they cannot perform it 100% correct, we will ask them, so what do you know about this procedure? They can outline from A to Z. They can outline everything correctly. But next question, when we ask them, so why don't you know the procedures, but why don't you follow? How come you skip certain steps? Then either they'll be silent, or they will say they forget, they were anxious, all sorts of that kind of reason. So actually, to me, they know, but maybe, those factors they forget, and most of the time they'll say they are rushing and so on, but those are the answers.
Just one last question, because until now, 2018, there were 4 near misses. Have the case been analysed, and were the junior doctors involved in these 4 cases were not from this 80%? 80% was being audited rather than come from the other group, or actually it's within these 80 people who have gone through the remedial measure?
The 4 of them is not from the study participants. The last case in October, it is involved in that houseman is involved in the post-remedial audit, but she did the near miss before the remedial CME conducted in her department.
Thank you very much.
Please, I have to congratulate you for trying to do an audit within the houseman. Not easy to do. But I think this problem is in every hospital. I think it should be done regularly as we move forward. I think the houseman is a very rare breed. I think one time we have to keep on insisting because we have this problem even in Penang Hospital, despite all the orientation they go through. So probably this can highlight the problem a bit more. Thank you.
Thank you.